Live. Okay, hi everyone. Just starting a minute or so early. Good evening. My name is Adi. I am a registrar working at Norfolk Park Hospital, and I'm also the webinar lead at Mind the Bleep. And welcome to the third session in our Geriatrics Crash Course. This session is going to be about a really important topic in not just geriatric medicine, but also in acute medicine, covering advanced care planning and do not attempt resuscitation discussions, which form a really important part of any acute medical presentation. And it's a really sensitive and challenging topic to get right. So we want to be able to, through this talk, show you how to approach these conversations with your patients and how to develop comfort and skills in having these challenging chats with the people that you are looking after. And next to me is Dr. Kham, who is a trust grade SHO working with me at Norfolk Park Hospital, who's got a lot of experience in geriatrics, as well as various other specialties, who's going to be doing the first half of our presentation. So just quickly, I just wanted to highlight the outline of our entire series. All of these events are going to be live on YouTube, and so please do join our career book page to get notifications for all of the subsequent events. But broadly speaking, this is the third session, as we mentioned, with advanced care planning and DNAR being our topic of conversation. The next session is on the 2nd of September, and I'm going to be talking about liaison and subspecialty geriatrics, so things like orthogeriatrics, cardiology liaison, and so on. And then there's a few more sessions planned after that in the coming weeks. These can all be logged as teaching hours, so please do attend, and you will get certificates at the end for attendance. So that's hopefully useful for you, in addition to the learning that we'll hopefully be able to pass on to you. So I'm going to hand over to Dr. Thaw now, who's going to talk through the first half of the session.
Hi. So today I'm going to go through around advanced care planning and DNAR, and mainly to go through the principle of what's the difference between them and some of the legal and ethical frameworks around these discussions, and also to differentiate between similar forms where DNAR, TAP, and respect forms, and what's the difference between them, and also understand how to document and communicate with patients and families that end of life care, as well as advanced care planning and what that involves. Let's go with advanced care planning. So advanced care planning is something we call in the UK, but in Scotland we would say as anticipatory care planning. So it's just a different term used, but basically the same. So advanced care planning is a voluntary process of a person-centered discussion between the individual and the care provider. So patients and either can be GPs or any, for example, palliative care nurse providers, or it could be just us like SHOs, registrars, anyone in. Mainly, most of them will be doctors, also specialist nurses, as I talked about earlier. So when we talk about advanced care planning, it centers around the patient, and it focuses at their preferences, priorities, what they want for future care. If they have one important thing is if they have mental capacity to have these conversations, and this is not a one-off conversation, and it would involve a number of conversations over time, and we have to be respectful about what's their wishes and emotions at all times, because this is focused on the patient and not what the medical management's going to go forward purely. So as a result, so the person should have greater sense of involvement and the opportunity to reflect and share what matters most to them. And I think this gives them more autonomy on how they want their care would play out like, and have a bit of control over life itself. So when is it important, and what do we do about it? So the appropriateness of medical treatment. So when we discuss about if it's these medical treatments, DNAR or advanced care planning, is when we think about whether the acute event of the disease is reversible, or if there's any feasibility of the intervention itself, what's the life expectancy, and the match between these benefits and care goals of an older person, but not necessarily older person. It can be a frail young person when we talk about advanced care planning. To define these goals, so that and values and needs of patients should be explored, and it's more of a regular process where it may have been triggered by multiple acute events, and it's important to discuss again the wishes and needs of the person, and it has to be shared decision making rather than um, medical team's decision purely. This is what makes it different from what we when we look at DNAR decisions. So the main universal principle for advanced care planning, like I said before, it's central to the person developing and agreeing the advanced care plan, and they decide who's involved. So if they have capacity, they can decide whether if their family, their loved ones who's going to be involved in that, and who else involved is us as healthcare providers and specialties, and depending on what kind of disease or issues that they have. And the person will have their conversation about future care, which should be personalized, and it should be focused around what matters most for them and what needs they have. Because sometimes we don't really know what the person would hold best as the best interest. For example, like they might want to walk around without dizziness. For example, if they have orthostatic hypertension, um, they might want to focus more on that versus the risk of stroke when you take medications like midodrine. They can kind of prone towards stroke. So what matters most is when if they want a better quality of life, they would choose that over having very high blood pressure and have a risk of stroke. And at that point, it becomes their choice to go through. And when I say personalized conversation about what matters most, it means that. So the person then agrees the outcomes of their planning through the shared decision making process with either family or also with the professionals as well. Um, so we have the duty to like record the, the patient themselves as well can report in what they want to do and share it with us. And we have a consolidated records which we can put as a universal care plan, which for example we use in universal care plan for the electronic records. Um, and another thing is, because we do this, the patient will have the opportunity to review and revise the care plan as needed in time, and doesn't have to be in one decision and one-off plan. It can be developed throughout what their disease and what's going on with their functional mobility and what's involving is in their social care as well. Anyone involved in care planning is able to speak up if they feel that these are not being followed. So that would involve the patient or the family, as well as the healthcare personnel. Everyone can contribute to this if above principles are not being upheld. So it's a short video about summarizing what we just spoke earlier. Just wanted to go through that. I'm not sure if the sound is available for this.
Should work.
Yeah.
No, not getting any audio. That's okay.
So if the audio is not working in here with the 5 steps, you can just go through the gold standard framework advanced care planning on YouTube. It's easily available. It's the same steps that we've just spoken about, the universal principle around the advanced care planning. Should I just?
I think let's head to the next slide.
Yeah, let's just go through the next slide now. So when are we going to start these conversations? So the main thing is we ended up speaking about advanced care planning and DNAR decision and treatment escalation plans when the patient comes in to the hospital with the acute events. When we say acute, is it death imminent? Or is it in hours, days, a few weeks? Or it's more like months or years? And sometimes when we say palliative care, it doesn't have to be in a few weeks or months of prognosis. It can be years, and it's just the fact that the reversibility of the disease itself is not impossible, and it's more focused on symptomatic and patient-centered care. And we have to understand about the fluctuation in health, and we have to explain that to the patients. So we have to be transparent about what's patient's baseline function is and what their comorbidities are, because these not the acute event only, but these reflect what's going to happen over time, and their baselines will decline with each of the acute events that they have in each admissions, and they might not be back to the baseline, and they may or may not survive the current admission. And another thing to notice is if they have multiple admission in the recent year, and this will trigger whether if we need to start advanced care planning or not. So it doesn't really just look at whether in geriatrics only. It's not just in patients with cancer only, but you have to look at what's their function, what's the baseline, how the frailty is, and it's how it is affecting their lives. So one of the helpful tools that you can have is it's called SPICT. It's Supportive Palliative Care Indicator Tool. It's used to identify people whose health is deteriorating, to see unmet supportive and palliative care needs. So this would be the SPICT tool. So it's used in palliative care. So the first thing is to look for any general indicators. So any urgent emergency admissions, and then whether if their function is deteriorating with limited reversibility, and progressive weight loss and muscle mass, and generally functional decline. And there are indicators for life-shortening condition. I'm not going to go into detail about disease specific. So you can have a look through around cancer, dementia, and in separate system around it. But the main thing is when we do advanced care planning, we look at current treatments and medication. We don't want polypharmacy to have lots of side effect and impacting the patient's function wise. So in advanced care planning, it's quite important to talk about their treatment and care and what their current treatments entails and what they want to avoid, and that is what matters most for them or not. And about holistic care, so when we talk about treatment, it shouldn't just be medication. It should also be around psychosocial. So what's their care at home? What's his or her social circle is like? What's their financial and spiritual need is like? So basically, how we can support. So health doesn't just depend on physical health. It depends on several things that we just talked about. So all of these things are important for patients, and it can be matter more than his physical health alone. So we have to talk about that in advanced care planning as well, if they want to talk about it. And another thing is when we have advanced disease in specialty wise, for example, either respiratory or hematological disease, it's always important for specialist advice. So when patient is not going back to hospital, it's also important for specialists to have some advice through the palliative care team. So it's also important to review these symptoms, and how are we going to review these symptoms? We discuss around that. So going through that, and we can agree our current and future care plan with the person or the family, depending whether if they have the capacity or not. And we have to record and also share, which is very important. We have to put it, not just keep it in ourselves, but have to share with across the hospital and the health record system, so that people can see and support patients' needs and the advanced care plan. Otherwise, it would just be recording ourselves, and doesn't make sense for them to do this at all.
And that include places like care homes, primary care, general practice, and other specialist hospitals that the patient may present to as well, just so everyone knows where we are in terms of the patient's trajectory and what's important to them.
Yeah. So who's involved? So like I said, for patient. So if someone has capacity, they should be involved in all decisions about their care, whether or not they have an advanced care plan, or they should always be involved in their care. But what if they don't have the capacity to decide all these things? And so one thing is, if they don't have it, then we have to discuss with the family. And one thing we have to find out is whether the family or the next of kin has lasting power of attorney, and their GP, who's they've been looked after, the nurses or social worker, who's allocated to them, and can work together as a multidisciplinary team to determine what's the best interest position. So that leads to our best interest meeting, where patient does not have the capacity. So it's designed to make a decision making on behalf of the patient, or the individuals who lack the capacity to make the decision themselves. So these meetings are generally according to the principles of Mental Capacity Act, which emphasize with the importance of acting in patients' best interests, and considering their past wish and current wishes, and their feelings, beliefs, and values, and what matters most for them. So the best interest meeting will also include an independent mental capacity advocate. If there's no one independent services, such as family, friends, who's able to represent the person, for example, rather than the main treatment team that's trying to provide the treatment and making the decision. So they have to have like a independent advocate for them if there's no family member. So what next? So when we talk about advanced care planning, it's a broad decision, but it can generate multiple documents. So the firstly, like we said, advanced statements or care plan, which includes the wishes and preferences and what's the importance and priorities that they want. And then another thing is whether if they want to refuse the treatment. So generally, patients can't really refuse the treatment if it's life-threatening, and if it's medically deemed important to be given. But I will talk about that more in detail in the next slide. So lasting power of attorney. So there are two types of lasting power of attorney. We have to be aware that there's health and welfare, as well as financial. We just need to clarify what's the type of power of attorney that the family has. sometimes they just have financial and welfare and not for health care. So it's quite important to clarify whether if that's the case, and we have to have see a copy if that is truly what they have. Otherwise, that would be not valid.
And the other thing with that, just to mention, is that lasting power of attorney documentation only becomes valid and enforceable if someone lacks capacity. So people will often do this whilst they still have capacity. But if they come into the hospital and they're unwell, but they have been deemed by the medical team to be able to make decisions, then the lasting power of attorney is not enforceable at that point. So whoever they've appointed will not be able to make decisions on their behalf unless their capacity deteriorates.
Yes, that's very important. It's only valid when the patient does not have capacity. So it's only valid when we are doing best interest meetings, basically. And the next one is respect forms when we have a look. So it's very context specific for emergency care and treatment care plans. So respect is focused on emergency care where patients get admitted to emergency. This is what the treatment plan, predetermined treatment plan that they want to have. And then treatment escalation plan is general for hospital admissions, which involve CPR status as well as savings of care, etc. And then these I'll go into details afterwards. So advanced statement or advanced care planning is not legally binding. It is quite useful to inform and guide decision making when patient does not have the capacity to make decision about their care. If they have these advanced care planning, it's quite helpful, and for us medical persons as well as the patients help as well. But the other ones, advanced decision to refuse treatment and lasting power of attorney, are legally binding, and we have to we're obligated to do so according to the advanced care. So advanced decision to refuse treatment. But that is mainly for the England, which I will go through now. So advanced decision to refuse treatment is a legal record of any treatment that a person does or does not want to receive in a specific situation. So they may decide they don't want to be admitted to hospital, whether if they get a chest infection or whichever infection that they would specify, and or any other type of disease. And it must be legally upheld in England and Wales, but not in Scotland. So for advanced decision to refuse treatment, it has to be legal and valid. It must be written in this specific way. So it has to be quite specific about why the patient is refusing and in what circumstances the refusal will apply. So it's not always that it has to be fixated on this thing only. We have to speak through with specialists if needed. So when patient wants to create an advanced decision to refuse treatment, they have to either speak to a doctor, a specialist nurse, and in some cases, palliative care nurses, to produce this document. And they may also wish to seek legal support because this is a legally binding document. So one thing is, patient cannot refuse care to make them comfortable or request help to end their life, mainly because when patients have terminal diseases, they may be depressed. And I think this, even though I say this, I think this will be reviewed in recent legislation changes around supports in terms of dying, assisted dying, but currently this stays in place where they can't refuse care to make them comfortable or request to help end their life. However, this ADRT is not a legal equivalent in Scotland or Northern Ireland, which means that even though they are not protected by law, they can still make an advanced decision like advanced care planning, but not legally required to taken into consideration by healthcare professionals. So what about DNAR? So DNAR is only focuses on cardiopulmonary resuscitation and doesn't cover anything else apart from this. So DNAR doesn't mean we're not treating the patients if they are having life-threatening moments. It just means that we're not doing a CPR when their heart suddenly stops or when their lungs suddenly stop. Uh, we have to be quite specific about when we talk about these things, and it's quite important when and how to initiate DNAR discussions, because it can be quite sensitive to patients because it's life and death for them. But it's quite different from the advanced care planning who makes the decision. So this time, this is not needed to be signed by the patient, mainly because this decision lies on the clinicians, lies on the treating um, clinician. That's so doesn't rely on the patient, whereas the advanced care planning is solely focused on patient's voluntary decision. So legally, um, clinicians are not obligated to provide any treatments that doesn't work, um, but sometimes patients and families can be quite resistant to the decision that's made around DNA CPR. So it comes, especially in these disputes, there's a role of second opinions. By second opinions, it means more towards the clinician or medical consultant. A second consultant needs to agree that this decision is to be followed through or not. Um, that is mainly about the DNARs. And what about respect when we talk about emergency care and treatment? So it's kind of like the summarized personal recommendations for a person's current care and future emergency. So when it's the same kind of patient's advanced care planning, but mainly focuses on emergency admissions, which around death or cardiac arrest. So it may or may not be limited to CPR, but also towards, for example, like IV treatments and things like this. So patient depends on patient preferences sometimes, depends on clinical judgment sometimes. So it would include both patients' preferences as well as clinicians' recommendations. It should be portable against cross settings, hospital, care home, ambulance. So, for example, if the patient is unwell, which hospital does the patient want to be brought to, and in what setting they don't want to be brought to the hospital for in emergency scenarios. So this is promoted by Resuscitation Council UK, and in this case, it will be shared decision making with the patients and the clinicians. And treatment escalation plan. So this is after being admitted. So on the admission, we have to think about what's going to happen throughout the admission. So they can further deteriorate. They can have the clinical condition changes throughout the admission. So we have to think about whether if this patient's going to need IV treatments, intubations. If their kidneys are failing, we would think about hemofiltration or dialysis. So depending on that, we have to make a treatment escalation plan, what to be considered and what not, depending on their frailty, comorbidities, and how reversible it is. And another thing is ceiling of care, where ICU or level 3 care, HTU level 2, and when we say ward-based, so ward-based critical care with some form of monitoring versus just standard ward-based care, or whether if medical emergency care calls are applied or not. So these ones are not really standardized across the different hospitals, but they will have localized form in each hospital. Maybe it's slightly different the way it's done. So these are just examples for the treatment escalation plan. So this would be more of a generic form, whereas this would be just slightly different, but basically the same information that we just talked about. And this would be DNAR form, which you would have seen before. So this can either be in hospital or this can be also in the community as well. We have to make sure that if we see patients in the community, if they have the DNAR form or not, whenever we decide for the pulmonary arrest. So what's the legal and ethical frameworks around this advanced care planning? So the main thing is Mental Capacity Act. So we have to presume capacity for the patient, that they have capacity before we start thinking about their best interest. So we have to make sure they can understand what's it and what things are entailed, what the decision making entails. They have to be able to retain this information. They have to be able to weigh the risk and benefits of what's going on, and they have to be able to relay it back to persons who they're making the decisions with. So only if those things are not able to be demonstrated, then it leads to best interest decisions. So another thing is common law duty of care. So basically, it's just mean that when we see a patient, there's an obligation upon the patient that we have to be behaving in best interest and not to have more harm towards the patient rather than giving medical treatment. So this applies in a way that best interests when we do best interest decision for the patient. And Human Rights Act. And the main principles would be focusing on patient autonomy, beneficence, non-maleficence, so that not to harm the patient, and justice for the patient. So the key point is DNAR decisions are clinical decisions, but family and patients should always be involved in discussion, but doesn't lie. The decision doesn't rely on the families and patients, but whereas the advanced care planning would more focus on the patients and families, depending on what their capacity is. So how will we start the conversation? So it really depends on context and information. We have to be quite realistic on how things are going to go for them. We like to make sure we're sensitive about the language used, because this is about someone's life and someone's last days of life or last year of life. So we have to make sure we're handling the emotional responses, and also be ready to talk about in short conversations, because sometimes they might not be able to continue the conversations in one go, and they may want to review and update each time. So it's quite important to involve the families if the patient wants, and so that we respect their confidentiality and give them a bit of time to discuss with the family and what they want, because sometimes the decision doesn't always rely on one person, and the patients may want to discuss with their families, their children, etc. So when the patient lacks capacity, we talked about LPAs and independent mental capacity advocates, and best interest decision meetings. So we want to for example, we want to make sure that we're respecting your wishes, especially in a medical emergency, and and I'll move on forward to how we would want to start. But the most important thing is we have to record the wishes. Otherwise, it's just conversation up in the air, and make sure we share the conversation and wishes across different settings, like Adi said before. So how do we start? So we have to listen before we start anything. We have to listen for the cues. What it is what patients and family knows about what's going on, and they might already know what's going on in their mind, and they will start thinking what happens if they become more unwell, and more deteriorates. Uh, what might what might happen to people important to them? What might happen to things that they um, care deeply? And sometimes it could just be they want to be um, at home and not want to go to hospital or treatment when they're more unwell. And if it's not getting better, and what happens when they die, sometimes they may have spiritual needs, and what happens to their body when they die. It sounds simple, but then these are quite important for a lot of people, and to everyone really. And we all have different spiritual and religious practices, and each to their own and quite important to them. So we have to kind of, when they start to talk about um, these cues are something to think about when we want to start conversation about advanced care planning. And this is when the patients come to us, and not when we want, when we think it's important. So regarding the clinical importance, we've already spoke about patient situation, which we can try and talk about. Whenever we talk about advanced care planning, the three main questions we need to think and talk about. This is from a palliative care website. So, what do you want to happen in the future? What do you not want to happen in the future? And who do you want to speak for you if you can't speak for yourself? So, it's just the same thing that we talk about in just simple language, just so that patients can think about it. Sometimes they might not be able to give the answer straight away, and you can always give them time to think about it and come back to speak about it. So, like I said before, you might want to use the word "what matters most," what's important for them, to help start these conversations. It's because its focus is on, when you say about what matters most, um, it kind of important to uphold their values and what's their needs and wants, and helps them to tailor their care in a very personal and holistic way. And documentation, it's quite important to document accurately and clearly. And what we should record is, we should record what's the rationale for decision, why are we having these conversations, who's involved in the conversations, and current date of review, what's and what the review entails, and what's the next review plan, um, and also digital records and cross-setting visibility. So when we say cross-setting visibility, it can be care home, GPs, hospitals, um, and the pitfalls are, sometimes we are too busy, or sometimes we are not really focusing on documenting it. The forms can be incomplete, and it becomes not legitimate, and it doesn't help the patient as well as um, the healthcare personnel. And also, ambiguous statements. It never helps if you're not clear about what's happening, and when the practicality is that when the emergency events actually comes, if the statements are not clear, people can't really move forward to the treatment decisions. So we now move on to case scenarios. Back to Dr. Gangal.
Thanks very much. That was a really useful overview of kind of the basic principles of how we approach these discussions. And I think it's really important to know the legal frameworks in which we ground all of these discussions, because that will guide how we implement them in clinical practice. I think it's always useful to kind of give some context with some real world examples of how this can take place. So I wanted to start with an imaginary man who I'm sure we've all met at some point during our medical careers. Let's call him Mr. Thompson, an 81-year-old chap who's come in with a background of advanced COPD and heart failure. Lives in a sheltered accommodation, but his daughter is very caring and comes and visits him every week. And he's coming acutely because he's hypoxic with type 2 respiratory failure, and his cognition is fluctuating. He doesn't have a known diagnosis of any cognitive impairment, so this is acute delirium. But this is his third admission in the last year with the COPD exacerbation, so he's coming in quite a lot. And he's never really had a discussion about resuscitation previously. Luckily, the previous admissions were all very brief, so it wasn't really broached. But as Kham was highlighting, it's important to have these discussions opportunistically, and unfortunately, this wasn't done previously. So your registrar has identified this and has asked you to have a conversation with the patient and his daughter about an appropriate ceiling of care. So what is an appropriate level of care in this patient? I think let's just kind of break down what's important when thinking about this. So we should never just use age as an absolute marker for whether someone is suitable for a certain level of care. But Mr. Thompson is frail. He's got multiple serious comorbidities with his heart failure and his COPD. And this is his third admission in the last year. So the overall trajectory for him suggests that his health is declining. So what level of care might be appropriate for a man like this? Well, let's go through it. So should he be for ward level active care, including things like oxygen and antibiotics? I think so. I think that's an appropriate level of treatment for him. He's likely to get better with this treatment, and so it's certainly worth doing this in his interest. Should he be for non-invasive ventilation? I think, yeah, he should be for a trial of this at the very least, because this is a potentially reversible situation, which might benefit from a brief period on NIV. So I think that's a fair thing to offer him. But then we get onto the more intensive and invasive options in terms of care. So should he be for intensive care, intubation and ventilation? Well, there's always nuance to this, but I'd argue probably not. And the reason for this is because, as we've discussed, he's frail, he's got a few comorbidities. And so when we think about this, we think about what the reversibility is. So will this lead to a reversible outcome in terms of a situation? Unlikely to be the case. Would he ever be extubated? It's difficult to say, but the balance suggests perhaps that's less likely. And then if his heart were to stop beating or he were to go into cardiac arrest, should he be for CPR? I think similarly, I don't think that CPR would be appropriate in a patient like this. So how do we discuss this with him and his daughter? Well, as Dr. Thaw was highlighting earlier, it's always important to communicate this with the patient and with his loved ones. So in his case, because there seems to be some acute delirium, it's worth thinking about whether we can make this decision wait until he's slightly better. But arguably in this case, he's acutely unwell, so we need to have this conversation and make these decisions at the point of admission. So it's important to then involve his loved ones, namely his daughter, in the discussions, not to ask them to make a decision, but mainly to kind of identify what's important to him and what his wishes may be. So let's see how we discuss this. So frame the discussion in the context of his general health. So acknowledge the seriousness of this illness and the limited long-term prognosis. So 3 admissions in a year is a fairly poor sign in terms of long-term outlook and prognosis. He's got a couple of comorbidities and he's fairly frail. He's in a sheltered accommodation. He's unable to look after himself. And these are important markers when we think about someone's long-term survivability. Ask his daughter what they think is important to the loved ones. So would he want to be kept comfortable? Would he want to kind of go through the process of something like CPR, which may or may not work in his case? What's important to him? And just clarify that we're still offering active care. So things like antibiotics through an IV, oxygen, giving someone non-invasive ventilation, and giving things like fluids are all fair game, I think, in this case. And I think this should be offered to him because they're likely to result in an improvement in his outcome. And emphasize that we're giving proportional treatment, not disproportionate things such as intensive care or CPR, because the chances are that he probably wouldn't survive some of those more intensive interventions. Again, clarify that you're not asking them to make the decision on the behalf of their loved ones, and re-emphasize that this is ultimately a medical decision. But I think it's important to just flag this up as something that we always like to discuss with relatives, because we want everyone to be on the same page in terms of what will and won't be done for the patient. And again, just to emphasize, the ceiling of care isn't about giving up on a patient, it's about matching the level of intervention to the patient's frailty and their wider condition. So there's always going to be barriers in some of these sensitive discussions. And so some of the ones just to think about are that, let's say you have this chat and the family think that the patient should be for everything. Well, it's not unreasonable for them to think about this. This is their loved one, they've grown up with them and so on, and they want them to have the best possible care. So then it's important to just reframe this discussion to emphasize that we're still giving active care, but it needs to be, again, proportional in the context of their general medical condition. Explain to them that CPR and ICU, even if they were to survive these intensive interventions, would realistically probably not offer any meaningful quality of life. And that's probably something that would not bode well for them in terms of their general outlook going forwards. And again, just reassure them that they're not being asked to make the decision for the relative, but this is just a discussion we want to have with them. They might also reasonably ask, can this not wait until they're better and less confused, because they may feel under pressure to make these decisions? But then I think here it's important to flag up that they are acutely unwell. And as such, I think it's important to have these discussions early on in the admission. And this needs to be clarified so that we have continuity across different wards and across different shifts. Because particularly at the start of a medical admission, someone will be in A&E, they'll then move into the medical take, they'll then move on to an acute medical ward, they'll then move into a downstream ward. So if we have this discussion at the point of admission, then it just helps set up the expectation for the rest of their medical stay. So he's gotten better. He's now safe for discharge. However, this has been a 2-month admission because he's become significantly deconditioned. He's now a lot more frail than when he first came in, and he's going to be discharged to a nursing home instead of his sheltered accommodation, and he's going to require round-the-clock care. Prognosis is... So essentially, he's been found to have a squamous cell carcinoma, which we often see with COPD patients. He wouldn't be suitable for a biopsy, and he wouldn't be suitable for a invasive or curative treatment. This has been discussed in the respiratory cancer MDT. Prognosis is estimated to be about 6 to 12 months. His cognition is improving, which is great, but there is evidence of underlying chronic cognitive impairment, which was previously not picked up. And when he is lucid, he's expressed several times that he really doesn't want to be in the hospital. He doesn't like the food, he doesn't like the noise, and he wants to be around his grandkids and to be able to watch the telly, which is all very reasonable, personally thinking. The daughter's been actively involved around a lot of his discussions with his care, particularly with regards to his cancer care. And so I think it's important to ask, should Mr. Thompson have an advanced care plan put in place? I think so. I think, especially highlighting some of the frameworks that Kham highlighted earlier, I think this is an important and opportune moment to have these discussions with him and his family. So how do we approach this in his case? So ask him, does he understand what's happened during this admission, how much more frail he's become, how unwell he was? Does he understand his new diagnosis of cancer and what this means in terms of his long-term prognosis? And if he were to deteriorate again, which is not unlikely, would he want to come back into the hospital? Or would he want to be kept comfortable wherever he is in the nursing home, for example? And what this is talking about something called a preferred place of care or preferred place of death. So it's important to tell him that staying in his care home with symptom control is an option. We don't always have to default straight to bringing people into the hospital if they don't want it. Obviously, from a medical standpoint, we always advocate for it, but it's always about framing this in the context of the patient's best interests and asking them what they want. So in his case, what is and isn't reversible? This is important to talk about in the advanced care plan discussions. So it's challenging sometimes to determine exactly what a reversible issue might be. Examples of this, generally speaking, might be things like high blood sugars, if he's had a fall and he's fractured his hip, if he's got a UTI, which is causing confusion, or if he's in urinary retention and just needs a catheter. I think these are all things that are quite, not necessarily easily reversible, but there's a lot of things that can be reversed in those presentations. It's important to highlight that we can never be sure as to what is and isn't reversible, but nonetheless, I think these are things just to point and put to him and to his family to see what their thoughts are. Oftentimes, being in a care home can help these issues to be picked up earlier because he will be seen by care home staff frequently and they'll be able to highlight a decline before he becomes very severely unwell. Whereas having carers at home, they'll come in twice, thrice, or 4 times a day. They'll only see him for a few minutes a day and they won't be able to necessarily pick up on the more subtle changes that we see early on in the disease. Something that's useful to frame these discussions is talking about the 3 Rs. So is the treatment that we're discussing reasonable? So is there a reasonable chance that he will respond to the treatment? Is it recoverable? So if treated, will he recover to a state that he finds acceptable? And is it respectful? So does it align with what this patient wants in terms of their ongoing care? That's just important to think about. So how are we going to do this? So as we were talking about earlier, I think this is a good time to create an advanced care plan on the patient's records. So depending on where you work, this might be through your electronic patient record, or it might be a paper-based document which can be carried on from one place to the next. In terms of things to highlight on this, talk about seedings of care. Community DNAR might be appropriate. Talk about when he might need to come into the hospital. So we talked about some of these things previously: UTIs, constipation, urinary retention. Consider admission for certain conditions, such as a fall with no fracture, or if he's got more severe pneumonia. But likely avoid admission if he's having recurrent pneumonias, if he's a lot more delirious, if he's losing a lot of weight and energy as a result of his cancer. And the key contacts are also important to put on his advanced care plan. So who will we get in touch with if he's unwell? So his daughter, care home, and the community palliative care team. This is a third scenario that I think is useful to talk about in someone who's in a slightly more stable scenario, but still it's important to frame. So Mr. Rahman is an 85-year-old man with CKD5 with diabetes as the cause. His eGFR is 12, so he's an end-stage renal failure. He's also got peripheral vascular disease. He's very sarcopenic. He's got advanced heart failure. He's frail, so the frailty score is 5. He's mobile with the Zimmer frame only, and he's got a twice-a-day package of care. He's limited independent functioning, but he is still cognitively intact. And he's been referred to the renal team because someone's thinking, should he be on dialysis because his kidney function has declined a lot? However, he has said that he's not sure if it's worth it. So what are our options in this case with renal failure? Number 1, transplantation. It's not really a realistic option for him. Now, we do sometimes stretch the kind of limits in terms of transplantation, but someone this frail and this age is unlikely to be suitable for a kidney transplant. Second option is peritoneal dialysis. So this is where we insert a catheter into the abdomen, which allows for dialysis exchange to happen. It's in theory a gentler option than hemodialysis, but it requires a degree of independence that I don't think that he necessarily has. There's also risk of infection within the abdomen, and that's higher rates in patients living alone. And heart failure also makes the fluid balance management more complex in a patient like this. So really, I don't think it's a practical option for him. Third option would be hemodialysis, which is probably what he was referred to the renal clinic for. So for this, we put in a line, so a testicular line, a portocath, or a fistula. And then he needs to come into the hospital, at least at the start, 3 times a week for dialysis sessions. And each of these is about 4 hours. The transport will take a couple of hours. So really, it's a half day, 3 times a week. There's a high likelihood that this will also progress his frailty because rapid fluid shifts can carry quite a significant risk in terms of hypotension, arrhythmias, and disequilibration syndromes. Also, just putting in a line in someone like this has its risks, so line-related infections, clots, and so on. And actually, in this particular cohort, so people over the age of 75, there's quite a limited survival benefit in terms of dialysis. So it only actually increases your life expectancy by around 4 months. But a lot of those 4 months are spent with increasing hospital admissions, coming in 3 times a week, and in a lot of ways, frankly, I think worsening someone's quality of life. So it's important to flag this up to him and his family. So this is where supportive care might come in. So it's something to offer and discuss with this patient. As we've seen, there's limited survival benefit in certain patients like this particular patient. Supportive care would entail ongoing active treatment for everything else that he has going on, but it would mean that he doesn't have to come into the hospital 3 times a week. And so that might be in his best interest. So how do we speak to him about this? So again, frame these discussions as something that he has power and control over. So particularly hemodialysis and supportive care, these are his choices and we'll respect what he wants to do. Explore what's important to him and contextualize what options we have. So dialysis, again, some survival benefit, but it's limited from a statistical standpoint. And he'll have to come in a lot of times. Supportive care would have some impact in terms of reducing life expectancy, but it avoids hospital admissions for longer and could arguably give a better quality of life depending on what's important to him. They may also reasonably ask what symptoms this may lead to if he's not having dialysis, fluid overload and uremia. And there are ways that we can manage this even if we're not putting someone on dialysis. So it's important to discuss that with him as well. And ultimately, our role as clinicians is to support this patient in making the decision that's right for him and that makes him feel the most comfortable. So see this really as an opportunity to consider broader discussions as well in the context of his other issues of ceilings of care things like resuscitation, advanced care planning, and so on, and involve the relevant stakeholders. So if he is very close to his family, it's worth speaking to them about everything going on as well. So I think those are just a few quick scenarios to frame and contextualize some of the really useful information that was flagged in the first half of the talk. But just in summary, do you want to discuss what how I'd summarize things?
So, like we discussed both in scenarios as well as the that I spoke before, advanced care planning should be a proactive, patient-centered care, and it should always be a voluntary process. But the thing is, the person needs to have a mental capacity to engage in these discussions at the time, and he needs to fully understand what decision he or she needs to understand that they what they chose to make about their future care. What if they doesn't have capacity? Then they can still be able to express their personal view and preferences through the people who are important to them and who they have expressed these views and values before. So it's quite important to explore these when even when someone does not have the capacity to discuss and fully participate. Um, so which is quite different from DNAR, where DNAR would focus on these decisions would focus on clinicians. And one thing to remember is this is not about withholding all the care. It's just mainly focusing on the CPR decisions when the heart and lung suddenly stops. Another one is respect and TAP. These are just there to bridge communication gaps where when the patient is brought to emergency center or brought to hospital, and when they can't really communicate at the time when they're unwell, these help bridge communication gaps about what they want and how they would be appropriate to be given care and treatment in hospital or emergency setting. In all of these, documentation and communication are quite important, and in a lot of cases, these are legal duties, whereas most cases it becomes ethical duties where us as clinicians are bound to do.
So that concludes the talk, but we're always really happy to answer any questions. I've just popped the feedback link in the YouTube chat, but also you can scan this code and this will generate a certificate that you can use in your portfolio. Please feel free to engage with us on the chat with asking any questions, because it's quite a nuanced and challenging topic. If you have any experiences to share, do feel free. Otherwise, hopefully it's been a useful talk and hopefully you have learned something from it. And please do come and attend our future sessions as well, because there's a lot of exciting content coming up as well. But thanks very much for attending, and thanks, Dr. Thaw, for coming in and giving us this really helpful talk as well. We'll just leave the chat open for a couple of minutes in case anyone has any questions or thoughts, and then we'll close the session.
It's just the
And these are just some of the references that we used to inform our talk. And there's a lot of useful guidelines here just to inform your own practice as well.
And the last link, advancedcareplan.org UK. It's a Wales website, but it kind of informs lots of different specific pathways where you can have a look through, and sometimes you can just direct the patients how to inform around these advanced care planning, because it's quite broad framework, and it's quite difficult to start looking around things if we don't know.
We'll just give it another minute or so, and then we will end the webinar. Great. Thanks very much, everyone. Looking forward to seeing you hopefully in the following webinars. And if you've got any questions, you can always put in an inquiry form on our website on mindthebleep.com. And have a lovely weekend. Thanks.